You are now on. Good evening, one and all. Today I feel privileged to welcome you all on behalf of Department of Physics, Janssens Institute of Technology, Coimbatore, to the international webinar on application of radiation in medicine. My heartiest welcome to our chief guest, Dr. Karthick Rajmani, who readily accepted our invitation to deliver his research ideas to the society. I welcome and thank our Janssens management, our principal, and my dear colleagues for supporting us in organizing and conducting the webinar. I welcome all the enthusiastic participants for their response and presence to participate in the webinar. Let me introduce our chief guest to you all, Dr. Karthick Rajmani. He is a consultant and a chief medical physicist in Radiation Oncology Unit, Dhaka, Bangladesh. He has completed his Doctor of Philosophy in Department of Physics, Jahangir Nagar University, Dhaka, Bangladesh in 2013 to 2019. His second doctorate is in Department of Medical Physics, Bharatiya University, Coimbatore, India, for which he submitted thesis and a final defense is pending. He is a board certified radiological safety officer. He is a professional member in the Association of Medical Physicists in India and an associate member of the Institute of Physics. He has 15 years of clinical experience as a radiation oncology medical physicist. He has undergone many professional training and experience too. More than that, he has experience in professional teaching and research activities too. He has 18 international publications. Now I welcome our chief guest to enlighten us with his lecture. Welcome you, sir.
Yeah, thank you. I think first of all, I really like the Janssens Institute of Technology and especially the Physics for providing an opportunity to be part of this webinar. I want to present with my webinar topic today is application of radiation in medicine. Just share my screen. Today, I think we are going to talk about the application of radiation in medicine. To start, before getting into the application of medicine, just I'll give us brief introduction about the electromagnetic radiation spectrum. Okay, the electromagnetic spectrum normally, as follows, we have radio waves, microwaves, infrared, visible, ultraviolet radiation, X-rays, and gamma rays. But mainly, today's topic is going to be more focused on X-rays and gamma rays. Okay, we divide the type of radiation into two categories. One is the non-ionizing radiation and ionizing radiation. Okay. So that's the I tried to explain the ionizing radiation and non-ionizing radiation. All these radio waves, microwaves, ultraviolet radiation, they have function like they don't have sufficient energy to ionize any atom. So they come in the category of non-ionizing radiation. Whereas if you see the X-rays and gamma rays, they have enough energy to remove ionization, or it can destroy a nucleus if you have a higher energy more than a 10 MeV of a photon, which can destroy an atom, and so that it can ionize an atom, and also you can destroy an atom. So that they come under the category of an ionizing radiation. So that in this today's webinar, we have mainly focused on ionizing radiation, which is we're going to talk about the application of X-rays and gamma rays. If you see the electromagnetic spectrum, normally if you see the energy wavelength has been decreased, so that the X-rays and gamma rays, which has an wavelength of 10 to the minus 3 nanometers, and the gamma rays, which is go beyond somewhere around 10 to the minus 5 nanometers. But when the wavelength got decreased, energy got increased, so that the radio waves and microwaves, which have an longer wavelength, but they have a very shorter energy compared to the X-rays and gamma rays. So the ionizing radiation, not only the electromagnetic spectrum, still we have some heavy particles and beta and alpha particle also considered as an ionizing radiation. Whereas in non-ionizing radiation, they comes in the lower energy spectrum. Some part of an ultraviolet is like in the high ultraviolet range. Normally they can still ionize the radiation, but still it's a very small range which can ionize the radiation. So we start with the discovery of X-rays, which is Wilhelm Röntgen in 1895 when he accidentally found a discovery of X-rays, and This is, but the best thing is, like, Röntgen found the X-rays in 1895. Like, this is the first image he got. Like, it's on Flora Röntgen's hand. This is the first image has been captured with an X-ray of 30 minutes of an exposure. But the main advantage is within a year of a discovery of an X-ray, like they started using in the clinical application. This is the first image of an colon fracture in 1896. They within 1 year of an invention of an X-ray, they started using in a clinical practice. If you see the nature of X-rays and gamma rays, they are more or less, if you see on a particular beam, there is no much of a difference between an X-ray and gamma rays. If you see a beamlet of an X-ray or a gamma ray as a single beamlet, it's one of the same. They fall in the same wavelength. The only difference between the X-ray and gamma is X-ray, or it has been produced from an outer shell process. Whereas gamma rays are mainly produced from from the nucleus. Because of the instability of the nucleus, we get the gamma rays. And normally in in medicine or in high energy physics, normally we always talk about X-ray energies in electron volt. Normally 1 eV we used to tell in a physical terms, it's 1.6 into 10 power minus 19 joules. Okay, we talk about X-ray production. X-ray production, there are mainly two types of X-rays. One is called Bremsstrahlung X-rays. The other one is called characteristics X-rays. I have a small animation here, how the X-rays are produced. Okay, just to assume, okay, this is an atom which has a nucleus here, and which is surrounded by K shell, L shell. We have a multiple number of electrons like 8 and 16. As you know, we have a nucleus. So that what happens is when a fast-moving electrons come very close to the nucleus, what happens? The nucleus is a positive and electron is negative. Suddenly, it got attracted and it got deaccelerated, and the loss of energy of this electron will be liberated as photons. That is called X-rays. Okay, so that the energy of X-ray depends between the distance between the electrons and the nucleus. If it goes very close to the nucleus, we'll have a maximum energy. If it goes slightly away from the nucleus, you will have an slightly lower energy of an X-ray produced. So that it purely depends upon how close it comes to the nucleus. And one more thing, as you studied in the class 7 physics, the X-rays is one of the least efficient process of producing X-rays. 99% of your electron beam will be converted. Only 1% of this electron beam will be converted into the X-rays. Like this is an Bremsstrahlung production, but this shows if an electron comes very close to the nucleus, we'll get the maximum energy of the photon. Okay, so that it purely depends upon the distance between the interaction of the distance between the electron and the nucleus. You get the spectrum of these X-rays. All these X-rays produced are not monoenergetic; they are a spectrum of energy. Again, there is one more X-rays used to call as a characteristic X-rays. Like this is also a component. Whenever there is an X-ray production, we always have a component of characteristic X-rays. Mostly, it is an unwanted X-rays. Normally, it gives more doses to the patient unnecessarily because we don't use this characteristic X-rays. But we cannot avoid this characteristic X-rays because it is an integral component. Okay, for an example, how the characteristic X-rays are produced. Okay, if you have an electron and just it removes an inner shell electron, what happens is suddenly an upper shell electron, like L shell electron, is jumping into the K shell electrons. During this transition, when the electrons jumps into the K shell electrons, there is a difference of an energy, and that energy will be labeled as photons. This is called characteristic X-rays. Why it is happening is when you have a K shell, which will be going much slower than the higher shell electrons, because for an example, your L shell electron is traveling at 100 miles per hour. Your electron will be traveling at 60 miles per hour. Okay, suddenly the 100 miles per hour velocity will be reduced to 60 miles. The loss of this velocity will be liberated as X-rays. Okay, that is the characteristic X-rays. So that this component will also there in the X-ray production, but it's a very minimal component which will be just as than a 0.5% of the X-ray production. If you get into the X-ray tube structures, like normally there are different components here. We will have a cathode and the anode, and all this entire component will be encapsulated inside an X-ray tube. Okay, so that and we have a focusing tube, which is the filament which is the electrons. Okay, let us start with the electron production. Okay, when we give an voltage to the filament, normally the electrons are produced, which is a thermionic emission. Okay, so that when we heat a filament, normally it emits electrons. Okay, that is a process we help us to use the production of electrons in the X-ray tube. And then anode component, the filament component is called the cathode, and anode component, which is which is the target, okay, which is mostly made up of tungsten, and we have a copper stem which tries to absorb all the dissipation of the heat, because as I told you, 99% of your X-ray has been considered as a heat, only 1% production as X-rays. So that we need to have an anode which can tolerate all this heat, and we need to dissipate all this heat. So that this copper stem with an water cooling system or an oil cooling system will help us dissipate all this heat and keep the target without varying any temperature and maintain the temperature there. So that the main focus, a main components of the electrons are focusing cup. That's you can see the number one, which is your electron gun. The second is the filament, and the third one is the electron stream, which when you give a pulse, the electron stream goes from the cathode to the anode. And the fourth, the entire blast tube will be set into a vacuum system. And the fifth mentioned here is the target. And the sixth one is the copper stem. And the seventh is the lead glass, because we need to avoid the unnecessary X-rays going out of the X-ray tube. And eighth is the when we have a production of X-ray, and then Berlin window X-ray exit for your clinical use. So that when you press the exposure button, normally what happens, it activates the low voltage circuit. I'll explain you. I have a circuit diagram in my few executive slides. Once you enable the low voltage circuit, what happens is it gives the low voltage circuit and started heating the filament, and the filament, the electron will come out of the target, and we apply the voltage between the cathode and the anode, and that will accelerate your electrons, and it hits the target, and we get the X-ray production. Okay, well, I think we get into the transformer. Normally, we work in the diagnostic radiology. We work up to something about 100 to 150 kV. So that we need to choose the amount of kilovoltage. So that what we do is we try to keep 65 kilovolts, 75, 70 kilovolt. So that according to the amount of kV we select, because for a patient with an fatty patient, which is something about has a higher thickness, record a higher kV, compared to when a patient is very thin, or I am going to do an X-ray of my hand, it doesn't require much of an kV, so that we will use a lower kV for a thin patient or pediatric patients, small child. We don't require something about 150 kV. We use 65, 70, 75 or 80 kV. So that this auto transformer will help us. If I want to set an 80 kV, automatically this auto transformer will set to the number of turns of 80. 110 volt will be multiplied to kilovolt, 80 kilovolt, and this has been applied between your cathode and anode, and we get an 80 kV of an X-ray. So that in a step-up transformer, what we do as you have a primary coil and as well as a secondary coil, which I give an 110 volt, which has something about 65 to 90 volt can be applied, and as the number of turns increase, you can step up your voltage from 65,000 to 90,000 volt, because we record a higher voltage to accelerate these electrons to get a higher kV energy. So that in relation with the various X-ray machine, when you do an exposure, okay, and you can use the timer, once you press the button, once the low voltage circuit get enabled and your filament got heated, and it gives some filament will be enabled, and when you press the second button, normally you double switch. When you press the second button, it gives an applied voltage between a cathode and anode, and using an auto transformer, so that the step down transformer will be used for your filament, that's your cathode, and a step up transformer will be used for accelerating your electron from your cathode to the anode, so that you have both the circuits in the X-ray tubes to have an X-ray in kilovoltage range. So that for an example, typically, if you have a timer and if you have an exposure button, once you enable the button, you have enabled the step down transformer and your filament got heated, and just it will pass through your electrons, and the higher voltage transformer, the auto transformer is get enabled, and this will accelerate your electrons from the cathode to the anode to the desired velocity, so that you get an X-ray. And mainly, as I told, this is very less efficient because in radio diagnosis, we do two kind of procedure. One is static radiography, and another one is fluoroscopic method. If you want to do a fluoroscopic, we will continuously irradiate the X-rays. But this stationary anodes, which is not very good for continuous irradiation, because it will have a lot of heat, and your target will burn. So that we need to have a rotating anode which is made up of a molybdenum, so that if you want to do any kind of radiographic procedures in a fluoroscopic mode, all these X-ray generators are made up of rotating anode type, so that you can get a continuous X-rays for something about 1 minute, 2 minutes. You can continuously get an X-rays, and the heat dissipation will be taken care by rotating the anode, as the electrons are not hitting the target on the same location because the anode is rotating. Let us get into the extent of diagnostic application. So that we have two different categories in a diagnostic application. One is radiography and one is fluoroscopy. For an example, in a radiographic mode, like normally if you have a fracture, you want to check any hip fracture, or you want to check any abnormalities in your lung, the normal radiograph has been used. But there are some interventional procedures in clinical applications, like patient has a block in the heart, okay, or some kind of an abnormalities where I want to use the radiofluoroscopic procedures. I need to just give a dye inside that, and I have to check. And like in a heart, they used to put a stent inside using the fluoroscopic procedure. So that for radiographic procedure, a normal stationary anode is good enough. But we want to do a fluoroscopic procedure, we need to have a rotating anode. So that how this X-rays or imagings are used in image, X-rays are used in imaging. Like traditionally, 20 years back, we normally use an X-ray cassettes to hold, when you have an X-ray falling through our hand, like here, as we shown, we have an X-ray cassettes hold there, and this X-ray, the X-ray cassettes, which has an films which converts the X-ray exposure to an flip. Like you can see here, how it looks. The hand bones are looking like here it is. So it will try to, the bone have a higher density, it will alternate all the bones, so that when it's passing through the hard tissues like a bone, it try to resist the lighter images, and when it passes through the air or a muscle, like you have a dense, like you can see when it passes through the air, you can see here it's all of black, so that we can differentiate. If any kind of a fracture in a finger or a hand, we can easily differentiate using this procedure. So that it can be done for different sites, like skull, face, spine, spinal disorders. People have a compression in the spine. You can just go and check with X-rays. You can see how much gap between the spines. Skull disorders, you have a fractures. Everything can be used. So radiographs can be widely used. And for chest X-ray, if you have an infection in the lung, can be identified using a radiographic chest X-rays. But getting to the imaging device, which is very interesting, like 20 years back, we don't have any very good imaging devices. We always use a film as an imaging device. But now we have a lot of advancement in the detectors and the flat panel detectors. I will explain you in the next further slides. And so that this is how we used to take an image. We put an image and just scan, most of them they have gone through this kind of an imaging. But the drawback of X-ray images are it's very laborious. Once this is exposed, you have to take it to the dark room. You have to just put it in develop a fixer. Normally it takes 20 to 30 minutes to process everything. And when you try to take an image for a chest, the patient is breathing, so that if you do a longer exposure, you'll have a blur, the image quality will not be good, and you are giving too much of a doses to the patient. And so that the next advance came in the camera-based images. How it works is you have an image and we have a detector, and these detectors will convert this X-rays into light using a thin film of a sheet which converts your X-rays into a visible light, and it will be captured by a camera and convert these signals into an image. But the main drawback with this camera-based image is, it's very poor light collection efficiency with this CCTV cameras, which is in out of 10 power minus 4. Means, I have possibility of capturing only one photon of 10 power minus 4 number of photons, so that the image quality was not as good as like a flat panel detectors. Then They started with a liquid ion chamber matrix, so that you have a different matrix of a chamber, and when the X-rays are started falling, it converts this collection of an ionization will be converted into an image. But the problem again is the resolution of the images. It's something about 4 millimeters, which is not very good, sufficient to have a very good quality data of an image. Which, like you want to find out a very hairline fracture, 5 millimeter of a resolution of an image is not really good. So that's the main problem is we need to do a frequent calibration, and the resolution of the detector is much larger, and it's not a build-up with an uniform build-up, so that you have a lot of backscattering it. So that flat panel is now we started using this flat panel detectors in our imaging for last 10 years, and it produces an excellent good quality image compared to the your camera based or ion chamber based, and it has a very linear dose response, and it has a very less dose to create an image. These are the image qualities of the flat panel detectors. You can see each and every bone very clearly compared to your film and the other things, with a less dose we can able to have a high quality image. So that the recent flat panel detectors are made up of amorphous silicon. Amorphous means it's non-structured, and the amorphous silicon absorbs the visible photons very efficiently, and it's used in many solar cells applications, which converts your solar energy into electricity, and it has an excellent substrate for photovoltaic devices. Okay, this is how the amorphous silicon panel look like. Like they have a build-up plate of a copper plate, and once the X-ray falls, it filters most of the X-rays and the scattered X-rays, and only the X-rays which is passed through the patient, which goes and flows on the poster screen, which is made up of gadolinium oxysulfide, and this poster screen will convert all these X-rays to a visible light. And this amorphous silicon, each pixels will capture this light and process the images. Okay, this is how a single pixel of amorphous silicon look like. You can see this is an photodiode, and you have a thin film transistor here. This is a bias voltage line, and this is a data line. Okay, so that for a particular frame, it absorbs all the light and keep it. This diode will keep it, and once this gate line is enabled, this whatever the charge accumulated, converted, from this visible light has been stored in the photodiode as a charge, will be go to the data line for the further processing. So that we are talking about a single pixel here, and if you talk about 1024 into 768 matrix, it's a lot of pixels, and this every rows, like you can see here, every rows will be enabled, and this data will be goes through the operational amplifier and get amplified, so that each row will be scanned, and everything happens in the nanoseconds, so that you'll really have a less dose. You have something about 768 rows. The newer matrix comes with something about 1600 rows, so that all this processing will be taken care, and we have an imaging unit which converts these data into an image. So this is how the microscopic view of this photodiodes and bias voltage line and the TFT transistor. You can see under the microscope is just a 0.3 millimeters of a size, and these are the detectors, and this amorphous silicon panels give an excellent image quality for a diagnostic images. So always, whenever you do any kind of an imaging, obviously you need to do an image correction, because without, we don't know how this photodiodes behave with radiation and without radiation. So that dark field is a response of the detectors without a radiation. Okay, so that these are the pixels. You can see a dot pixels here. These are the dead pixels, but still we can average it in between more, because these have a lot of pixels with a 0.3 mm resolution. We cannot expect all these detectors should work initially. On the gradually, when it becomes 1 year and 2 year, we'll get a lot of dead pixels. But we have a software which can average the pixel. Where there is a dead pixel, we can average it. So that this is how a dark image looks when you, without any radiation, just I enabled my bias voltage, we get an image like this. Okay, and we just expose the radiation on this flat panel detectors. We used to take, that is called a flood field. So that this is how the radiation has been responding. I'm giving a same dose to all the pixels, and there will be a vary how each pixels will be responding to the radiation. So that we used to call flood field. So that the image correction will be done. You take an image that has been subtracted from the dark field, and it has to be derived from the flood field, so that the response of these detectors has been corrected, so that the enhancement of your image quality have been further increased. So that if you see an active area of these panels is something about 30 into 40 centimeters. If you, these are very old panels, the new panels which we have a resolution of 768 in 2024, or the latest panel which has some higher pixel which goes something about 0.15 millimeters. And again, the important thing is like how actively, because the radiation is not good for all patients. Okay, we need to expose as less as possible, so that when you have a time frame, when this processing of this each and every row, we need to enable the synchronization between the panel as well as the X-ray tube. We can reduce a lot of doses to the patient, so that we have a different, this repeat rate is a different dose rate. Like this is I given 100 centigrade for 1 minute, if it's a repeat rate 2 is 200 centigrade for 1 minute, 300 centigrade for 1 minute, so that this really, this synchronization between this flat panel imager and the machine, okay, really it can reduce. Otherwise, we'll end up in giving this much of a dose. Once you do a synchronization, you can see a small amount of a dose, and after that the beam will be stopped. Then the image is not processing anything, and we can enable, so that this synchronization of this image panel and the X-ray tube is very important to reduce the dose. Otherwise, I can give 10 centigrade, I can reduce this dose to 2 centigrade, because increasing the amount of radiation for diagnostic purpose, there are chances of secondary cancer because of the radiation, so that we need to avoid as much as possible to get a very good quality image. Okay, let us start with the nuclear medicine. Nuclear medicine is something about, it's also a diagnostic imaging, and it's a form of a physical in order to produce images of a physiological process. We utilize radioactive isotopes, which typically emit gamma rays or any other type of ionizing radiation that can be detected. Okay, so that these isotopes have half-life. Half-life is something about the activity will be reduced, the amount of time required to reduce your activity to its half. Most of these radioisotopes used in the nuclear medicine have a half-life, something about in hours, or some of them which has something about 4 to 5 hours, or some goes up to days. So that these isotopes have either been injected into the patient intravenously or inhaled, where depending upon the carrier substance, they concentrate in an organ of an interest, and it emits gamma rays and detected by the gamma camera and other detector devices, and they are displayed on the cathode ray tube on the screen, so that you can really see what is happening inside the patient. The special terms of this nuclear medicine reports, including such as hot, photon rich, cold, or photon poor. These are the terminologies used sometimes. We use to understand how this hot means how much activity in a particular organ. Okay, this will help us to understand how your physiological purpose of a particular patient or a particular organ can be identified with the nuclear medicine. So that nuclear medicine is not an anatomical imaging. Anatomical imaging is nothing but a CT scanner. Like you do a CT scan, you can see anatomical imaging, but it doesn't give an idea how it functions. Okay, so the nuclear medicine is a type of an imaging which gives a physiological imaging, which otherwise also called as a functional imaging. Okay, so that in the conventional nuclear medicine, always we try to use an gamma ray emitter, which creates an image. A particular device called SPECT, single photon emission computed tomography, and these gamma rays are of such of an energy level that can be easily directed by the gamma camera. The SPECT imaging is conventionally nuclear medicine, where by rotating a gamma camera around the patient object of interest, we are able to create a three-dimensional array of data demonstrating the location of the gamma rays. I will show some images, for a demo images, how you can predict these images. And the tomographic images can be fused. The CT images can be also fused with this functional imaging for further understanding. This is how the gamma camera looks, and the gamma camera has an detector with a cathode ray tube, which all these gamma rays come from the body, will be detected by these detectors and will be amplified and shown in the gamma camera, so that this will be help for a physiological understanding of how your organ works. And this is a typical example of an bone scan obtained by a planar imaging over an anterior AP and a posterior AP. Here you can clearly see an uptake here on the skull as well as on the particular bones like somewhere in the lumbar. So that we inject a technetium 99M radioisotope inside the body, and we used to scan after something about 45 minutes to 50 minutes, and we can see, and this imaging will really help us to understand if there is any kind of an abnormalities in the bone using a technetium 99M isotopes. This slide demonstrates the appearance of the lung as obtained by the lung ventilation perfusion scan. The ventilation, on the left side of your screen, you can see the ventilation scan, and the perfusion is on the right side of the screen. And the ventilation scan consists of the patient inhaling air gas, which is an isotope of xenon 133, or particles of a technetium also, which will be grouped inside, which is also aerosolized and distributed through the ventilated portion of the lung. On this, using this scan, we can really identify how good is your lung is functional. Okay, like if you take an X-ray, we cannot understand how much of your lung is functional lung is available. Okay, so that this kind of a lung study with an xenon 133 isotopes, we can clearly understand your full component of your lung is working or only a part of a lung is working. So that this will be really helpful to study a patient's lung performance study. And this is another scan which is used to to study the hepatobiliaries. That's nothing but the liver studies. And here we can understand whether the bile duct is properly working. And you can see this contrast enhancement area which has been given by the isotopes really help us to understand your liver function and the gallbladder function is exactly as normal or not. Otherwise, if it's not functional, normally the uptake of the trees is very minimal. Get into the PET-CT. PET-CT is a very recent advancement. Last 10-15 years, it has changed imaging system, and it gives a very precise definition of tumors and other things. I will explain. I have a video on this, how we use the PET-CTs. The PET-CT have two gantries. One is for the CT, and another one you can see here. One inside this one. The first one, which is the CT scan section, the other one is the PET scan section. It does two images three-dimensionally and try to fuse between these two slices so that we can find an anatomical imaging as well as an functional imaging together. So the PET scanning can be helped in oncology, which is for the cancer treatment, and for functional imaging, metabolism, and perfusion studies. Okay, so that how the positron emission tomography works. Normally, what we do is we created an F18 fluorine using a cyclotron, like bombarding like a protons to produce your F18, and beat this F18 with a glucose. As you know, people know this all these cancer cells have a metabolic activity compared to a normal organs. So that when you inject an isotope which is emitting positron and doped with the glucose, all will go and deposit where the metabolic rates are very high. So that, and these isotopes which is emitting a positron, that's fluorine 18, which gives a positron which have an energy of 511 keV emitted, and they used to get into collide with the free electron which is available in your body and emits an photon on 180-degree angle. Okay, so that when you come a positron and a free electron, it gives an gamma rays at 180-degree angle. These gamma rays will be detected by the PET detectors, and it is a synchronized detectors. It has a 360-degree detectors, and it tries to exactly find out which location this particular point has come from, and it will put a lot of multiple points, and it creates a three-dimensional image. So just I'll share the screen of how we do this. Just give me a second so that I can show the video of how it goes. Okay, this is a video which is we are going to explain about the PET injection. Now you can see, like, after 30 minutes, it will just, stay in the area where you have a higher metabolic activities, like in the bladder, because, the entire isotopes will be, like, dialyzed and, get into stored in the bladder, and in the kidneys, because it will be where it gets secreted, and the brain where you have a more metabolic activities. Okay, so let's just run this video again. So that you can see, like, this is how you looks like, when you have this, like, cancer cells, you can easily identify it using this, because the cancer cells will have more metabolic activity. Just I'll go back to my screen. Just a minute, sorry. So that like, you have seen, like, this gamma rays which are coming at 180-degree angle, and this detectors used to find it. So that you can see that there's a tumor in the liver here, and this is when you try to combine.
Sir, excuse me. Share your screen.
Yeah, sorry. That's fine. Hello.
Yes, sir. You can take it.
Yeah. Okay, here it's a typical case, like, how it looks like when you see do a CT scan. You're not able to really identify whether there's a tumor there or not. It looks like everything is normal, but when you try to use this PET CT, due to the higher metabolic rate, you can exactly see, like, how good the activity is, because we can identify the entire tumor here very clearly. And this is a kidney, like, as when you start seeing this lot of imaging, so that we can clearly understand whether it's a normal uptake or it's a cancerous cell. So here we can easily find it's a clearly identifying of a tumor in the liver. And it's also this tumor, like, always has a tendency to spread into other structures. It's a typical case of a lung tumor. You can see here there's a lung tumor, there's an uptake here, and it always get into the mediastinal nodes. So that this PET CT will help us to do a staging purpose, and how much it has spread into the other parts of our body can also be clearly identified using the PET CT. So that in case it's not only there's a tumor, the tumor also spread into the mediastinum. You can see a big mass here using a PET uptake, so that the PET imaging will gives a clear idea, like, how much the tumor has been spread throughout your body, so that it really helps us to understand the staging workup of all the cancer patients. And this is a typical case of a cardiac scan, which we used to call a perfusion scan, can be done on an or a PET CT, or as well as SPECT CT, which can be done. And the images represents here showing a cross-sectional images through the heart and the tomographic fashion. And in this case, radioisotopes utilized for, we used as an ammonia here, which has a short half-life, which is a positron emitting isotopes. And this particular technique will help us to understand, how your cardiac functioning is, really good, or you have any problem in your structures. So normally in the CT, we cannot identify your cardiac is working fine or not. But using this perfusion images, we can clearly understand you have any deformities in your cardiac scan. So that if here in this case, this is an ischemia is nothing but there is a block in the blood flow. So that if we can see the anterior wall of this heart, you can see there's a less uptake here, so that there is not much of a blood flow in the heart, particular area of this heart. So that it will really help us to understand, like your anterior part of your heart is not performing normally. But in the CT scan, if you do only the anatomical scan, we cannot really identify these things. So that this kind of a perfusion scan really help us to understand, like whether it will exactly give you a functional imaging of your particular organ, like heart, liver, and everything. And this is a typical example of an anterior wall ischemia. Like you can see, a very less uptake in the anterior wall compared to your other areas. And this is also a typical example of an perfusion scan. Like we are using an 13 ammonia as well as an 18 FDG. We did a feasibility study on a PET imaging using an ammonia as well as FDG. But still, we can also use an fluorine 18 also for this cardiac studies. Okay, like let us get into the last section, which is our radiation oncology part, which is my area of specialization. Okay, radiation is a very effective tool of treating cancer. At least 60% of the cancer patients require radiation as a part of their treatment, and radiation oncologist or a cancer specialist who manage to care cancer patients, it can be an intent, can be a curative or become a palliative intent. Okay, how this radiation works is, when you give a high energy radiation, like normally the radiation oncology, we normally work in high voltage, not in kilovoltage. The kilovoltage X-rays are used only for diagnostic purpose, and we always use a megavoltage radiation to treat cancer cells. So that there are two types of damages happens in the DNA level. Whenever we give a high dose of radiation to any particular cancer cells, normally it can directly break the DNA. The second thing is, it can create a free radicals, and it will be a very highly active radical, and it just destroy the DNA strand. So that it can be a direct hit or it can be an indirect hit. So that this is how the radiobiology works. When you give a high dose of a radiation, concentration radiation to a particular area or a particular cancer cells, it will directly destroy the DNA strand and it cannot multiply further. So that we can kill the cell by destroying the DNA strand. So that the 4 R's of radiobiology, what we call is repair. Okay, so that we give something about 2 grams of radiation every day, and we give we give 2 days gap in a week, so that when you try to treat a cancer patient, we don't only treat the cancer cells, we also treat some part of a normal tissue, so that they give us some kind of a fractionation scheme to to all these normal cells to recover. And all these cancer cells can regrow between the fractions, so that we need to be careful. The normal tissue can recover, but the cancer cell should not get recovered, because it's not good for the patients. The redistribution is something about, it's a very radiosensitive phase, like the G phase of a cell cycle, it's very sensitive to the radiation. When the cells are in the G phase, normally when you give a high dose of a radiation, it gets destroyed compared to the other phase of a cycle. And hypoxia is a very important terminology. When you have a large amount of an oxygen concentration and you give them radiation, you have the cells will become more sensitive compared. If you don't have an oxygen supply in this cancerous cell, they'll be less immune to the radiation. So that the high concentration of an oxygenation is very important to kill this radiation. So that this is there are 2 ways, 2 intents to treat the patients. One is curative intent. Our intent is to try to save this patient. Another type of radiation where we use is a palliative intent. We try to give an symptom relief. A patient have a lung cancer, it can spread into bones. We will have a tremendous amount of pain, because this cancer cell is just eating the bones. So that by giving a high dose of a radiation to this particular area of a bone, so that the patient will be in high pain, we can give a high amount of radiation to the particular area of a bone, and we can reduce the pain. Within 1 or 2 days, we are able to reduce the pain. That's the intention, is just symptomatically we can cure them. We cannot cure the patient, but symptomatically we can give a pain relief. That is called a palliative radiation. And radiation obviously has a lot of side effects, but we need to be careful. With the modern techniques we have, we can avoid a lot of side effects, like patient having a vomiting sensation and skin erythema, a lot of skin reactions. You can see when you try to treat a breast patient, we have a lot of skin reactions. So that with the newer techniques, obviously we can reduce the amount of toxicity. We can Get so the common side effects, if you can see, like when you want to treat a breast patients, you have an skin redness, swelling. You have a difficulty in swallowing the food. When you try to treat an abdomen, you have a liver cancer or stomach cancer. We always have a nausea, vomiting sensation, diarrhea. So there are a lot of side effects also there. But within higher techniques, like we have a modern simulation system, which can really reduce this kind of side effects to minimum. So that for radiation oncology, it is not a single man army. We have a team of specialists, radiation oncologist who is a physician, who is a doctor, who give advice and who just define the area where he want to give a radiation. The medical physicist, who we do the planning of each and every component and try to avoid all the normal tissues, and we try to give a high dose to the cancer cells and try to avoid all this radiation to the normal tissues and the critical structures. And the radiation therapist who try to give the administrate the radiation on the supervision of the medical physician and the doctor. Let us start with the machines, what we use for this radiation therapy. For last 50 years, this cobalt-60 has been used as it's a recognition, and we use an isotope. It's a gamma emitting isotope, which is the cobalt-59, which will be bombarded with a neutron. We get a cobalt-60, and it emits an energy of 1.25 MeV. And this has been used for something about last 5 decades for all the cancer patient treatment. This is how the machine looks like. The patient will be lying down on this couch, and the machine rotates. And wherever there is a radiation, we can give a focal radiation to the cancers, only to the cancer cell, and we can avoid the radiation to the other part of the radiation. And this will be different machines, this is how it evolved. And this machine can rotate clockwise, all the 360 degree. The patient can go in, go up. According to the site of a tumor, we can arrange this machine. This is the internal structures. The shielding is also very important in this machines. You can see this, the entire thing is a lead shield, and we put a cobalt isotope here, and a pneumatic pressure. Once you switch on the beam, this pneumatic piston will, using a pneumatic pressure, this piston will be moved, and this source will come to the direct position, and it will started giving the radiation care. And otherwise, once it's switched off, it goes to this position where we used to call it the safe position, where it's under the shielding. The new mission, which is the linear accelerators, last 20 years, this has been the main mission for the cancer treatment, which is called linear accelerator. We used to call linear accelerator because it accelerates the electrons linearly. Normally, it accelerates the electrons to the velocity of the light. Okay, and I will show a small, it's an 8 minutes video of a linear accelerator, how it works. Then after that, we'll try to. So this video will show you how the linear accelerator works.
Radiation therapy uses this principle to damage beyond repair or kill the abnormal cancer cells in a tumor. Successful radiation therapy depends on the ability of the linear accelerator, or LINAC, to deliver a tumoricidal dose of radiation to the tumor, while ensuring minimal radiation of normal tissue. The LINAC accurately produces, monitors, controls, and conforms the radiation beam to the planned target. Beam generation. Radio frequency waves are pulsed into the waveguide by the magnetron. This is synchronized with the injection of electrons into the waveguide by the electron gun. The radio frequency waves accelerate the electrons along the waveguide to a speed approaching the speed of light. The X-ray beam is created when the electrons hit and interact with a tungsten target at the opposite end. The magnetron controls the power and frequency of the radio frequency waves, which determine the energy of the X-rays produced. The digital accelerator uses a diode-type electron gun situated at the end of the waveguide. The The electrons are produced by heating the tungsten filament within the cathode and are then injected into the waveguide. The number of electrons injected is controlled by the temperature of the filament. The electrons are accelerated along the waveguide toward the target. The waveguide contains a series of copper cells. Small holes, or irises, between these copper cells allow the electrons to travel along the waveguide and help to focus the beam. A vacuum is created to ensure that the electron beam is not impeded by other particles. The path of the negatively charged electron beam is controlled by two sets of quadrupole magnets, called steering coils, that surround the waveguide. An additional two sets of focusing coils help to further define the electron beam so that it is very fine, with a diameter similar to that of a pinhead when it hits the target. The entire system is cooled by water. The electrons exit the waveguide and enter the flight tube, where the beam is redirected towards the target. The electrons travel along a slalom path within the flight tube. 3 pairs of magnets on either side of the flight tube cause the electron beam to bend through the turns of the slalom. This process not only positions the beam to strike the target, but it also further focuses the beam to a diameter of 1 millimeter. The design of the magnets enables them to focus electrons of slightly different energies onto the same point on the target. This is called achromatic behavior. This slalom bending is unique to electrolinear accelerators. It helps to minimize the size of the machine and ensures that its isocenter remains low, which is important for patient setup. The high-energy electrons hit a small tungsten target where the electron energy is converted into photons, or X-rays. The high-energy photons emerge from the target in a variety of directions. The primary collimator only allows forward-traveling X-rays to pass through, creating a cone-shaped beam. The primary collimator minimizes leakage, and therefore excess total body dose, by absorbing scattered X-rays traveling in the lateral direction. It also defines the maximum size of the resulting clinical radiation beam. At this stage, the photons are not uniformly distributed across the beam, and so a flattening filter is placed in the path of the beam. The cone-shaped filter absorbs more photons from the center of the beam than from the sides, creating a uniform photon beam. Dose measurement. The photons now pass through the ion chamber for dose measuring and beam quality monitoring. The dose delivered to the patient is measured and controlled simultaneously in 2 independent ionization chambers. One chamber is the primary dosimeter. It measures the radiation and terminates the beam when the required dose has been delivered. The secondary ion chamber acts as a backup and will stop the irradiation if the primary chamber fails. The treatment machine must replicate the beams modeled within the planning system. This is critical to the accuracy of treatment delivery. A beam quality function is performed by a third ionization chamber, which uses 7 electrodes to monitor different sections of the radiation field. The X-ray beam is almost ready to treat the patient. Before that, further beam shaping is required to ensure that the shape of the delivered X-ray beam matches the shape of the tumor. This is done using a multi-leaf collimator, a number of fine tungsten leaves which move independently of one another and can create a variety of complex treatment shapes. LINAC control. One computer system controls both the LINAC and the multi-leaf collimator. This eliminates dosimetric errors due to communication delays. It also ensures synchronization between the delivered dose and the multi-leaf collimator position, allowing complex deliveries such as intensity-modulated radiation therapy and volumetric modulated arc therapy. All electromagnets, steering, and focusing coils are digitally controlled. All mechanical positions of flight tube, filters, and foils are automatically selected from the control console, and all radiation beam settings are grouped in calibration blocks for each energy. These are stored digitally on the Linac hard disk for flexible and easy beam adjustment, calibration, and servicing. Clearance. Clearance is the free space available under the Linac for patient treatment, and it varies with different protocols and fixation devices. It is a combination of the distance between the lower surface of the radiation head and the isocenter, 45 centimeters, and the head diameter, 62 centimeters. A wide clearance around the isocenter means improved access for patient setup, freedom to use the best possible patient positioning and immobilization accessories, freedom to rotate the gantry between fields without needing to move the patient. Finally, it means that treatment techniques using non-coplanar beams are not compromised. The large clearance offered by Elekta machines ensures flexibility in providing the best possible treatment for the patient.
Okay, as we see, this is how the linear accelerator works. Normally, this machine it costs somewhere around $2.5 million, and it has all this physics and engineering. Everything has been as a part of this machine. It's a wonderful invention, and a lot of cancer patients, like around 60% of the cancer patients, need radiotherapy as a part of their treatment. So these are the machines we use for treating the cancer patients. Given high dose of radiation to this cancer cells and try to avoid all the critical structure as much as possible. The again important thing is I think there are some civil engineering students also available in this webinar. The important thing is about this bunker design. Okay, mainly especially if you see this kind of an energy when you try to build these bunkers, we used to call it a bunker, and the energy of this machine is very important. Normally this machine, what we have shown you, which can produce a maximum energy of 15 megavolt. So that the kind of a bunker we have to design is something, according to the Atomic Energy Regulatory Board, in this console area we cannot exit more than 1 millisievert per hour. So that there are radiation workers lying here, okay, so that they can maximum receive 20 millisievert per year. So that we have to control so that you cannot receive 1 MR per hour during the operation of this Linac. So that we design it, you can see this when the beam rotating around this is called the primary walls, which has a thickness of something about 1.5 meters of concrete, high density concrete. So the designing of these bunkers, we need to have a clear understanding of how this beam alternate and how it interact with this kind of materials with this and everything. So that we need to have a clear idea to design these bunkers, and we need to know what is an HVL half valley layer, how much thickness is required to reduce the intensity to 1 MR per hour outside the radiation area. If it's a public area, we need to reduce further less. So that it's very, very important to understand the physics as well as the density of the material. What we use for the construction is very important. And this is the typical electronic configuration of this machine. As we see, this is how the electrons come out. They get an acceleration. This is another vendor which is called Varian. What we're seeing is an Electron model. They have a Stallman bending, but here it's a 270-degree bending magnet. The electron comes here, it bends like this, and it hits the target. Okay. So that if you can see the material, we talk with in the video itself, if you are carefully seeing, there is something called a flattening filter, because the center intensity of the X-ray always on the center is high and on the periphery it is less. So that we use this flattening filters to make the beam flat. Otherwise, your center intensity will be more and the periphery will be less. So that these flattening filters, according to for different energies, there will be different flattening filters will be there. According to the energy selection, this will come directly under the beam and it flattens the beam. And this is the other component called corrosion. Like this entire assembly is called corrosion, and you have flattening, like flattening of scattering foil, which is used for electron beams, and really it will help us to if this machine can produce electrons as well as photons. So the scattering foil will be used for electron beams. So this is how the bending matter system works. If the electron is having a particular energy, if the energy is not within the range, it will dissipate as a heat. Only the energy which is having a particular energy can pass through this bending magnet system, otherwise it will getting dissipated as heat, and it goes a 270-degree bend because electron will be get deflected using a magnet, and it will hit the target. And if you see the penetration depth of these different energies, you can see as the energy increases, the penetration depth increases. Because when you want to treat a bulky patient, you need to have a higher penetration. If you don't, if you use a lower energy, like it will give a lot of dose on the skin. So that on the deep-seated tumors, you need to use a higher energy, and for superficial tumors, you try to use a lower energy or electron beam. So if I try to use a cobalt beam, this is what happens. When you treat a cobalt machine which has an energy of 1.25 MeV, you can have a lot of skin effects on the patient. So that using a higher energy with this linear accelerators, we can really avoid this doses to the skin, and we can give a high dose to the deep-seated tumors. So the treatment planning is a very important concept. Like what we do is we do a CT scan and we import the entire CT scan, and the radiation oncologists do the area of interest where they want to give a radiation, and we as a physicist, like we do the plan, and this plan will be computerized transferred to the treatment machine. And so that this treatment planning system, which has a modeled beam, like how the beam output of the machine has been modeled, and we're using a Monte Carlo simulation, we can simulate the dose, how the doses will be on the patient, we can simulate. And I'll show you, this is how we can simulate the dose on the patients, for different techniques. Like if I give only a 4 beams, I will get a dose of the full area. Like you can see a rectum here and the bladder in the above region, which also gives a high dose. But when I try to change the intensity of the radiation beam, I can give only to the cancer area. You can see the only area where there is a cancer cells, I'm able to give a radiation, and other areas will be get spared. Okay, this is possible with the new high-end techniques. With this computer algorithms, we can able to model the beams, and we are able to give a high dose of radiation only to the structure, only to the tumor area where we want to give, and we try to save the other structures. But without that, otherwise we are going to give the same dose to the tumor as well as to the normal tissue, which is going to be more toxic to the patient. So that intensity modulation radiotherapy is going to really help us to modulate all the intensity of the radiation and give a high dose of radiation to the tumor cells, and try to avoid the normal tissue as we have shown here. So that these are the high-end techniques which has been evolved for last 10 years, like really started implementing in the clinical forum, and we giving a lot of advantage to the patients with less toxicity to the patient. Therapeutic radiotherapy is something like we give a very high dose of radiation instead of normally the radiation doses we used to schedule for something about 5 to 7 weeks of a treatment. This therapeutic radiosurgery treatment, like if there is a very small tumor, like we can give instead of in 7 weeks, we are able to give in a single day fraction. We can give a high dose and we can cure the patient. So this is how we used to put a backlog, we used to, because stereotactic radiotherapy or stereotactic body radiotherapy, we need to make sure the patient doesn't move during the treatment, so that we put a vacuum cushion, and we used to take all this vacuum out so that the patient doesn't move, so that we can accurately treat the patient very particularly. And the proton beam is an very it's there, but it's a very expensive machine to treat a radiotherapy, where the exit dose is literally zero compared to the X-ray beam, but it's a very expensive machine. Normally it costs somewhere around $100 million. We have one in India, in Chennai, and there are something about 10 to 20 machines available all over the world, and but it's very expensive. But still, it gives an it's not fit for all the sites, but it does a very great job especially for the pediatric patient and other things. And there are some internal radiation therapy. What we do is we put an radioisotope inside the cancer tumor, and we try to irradiate the tumor. So that there are some cases where we do an implant inside the tumor and we put the radioisotopes and we treat the tumor, so that these kind of called intracavitary implants, interstitial implants. And we're using isotopes like iridium, cesium. We can give an brachytherapy. We used to call that's called internal radiotherapy. So that what we do is we put all these radioisotope seeds. This is a prostate implant. We put all these radioisotope seeds inside the patient, and then after that, once the patient, patient has been exposed to one particular time, then we remove the entire thing. So that this is called brachytherapy. And intraoperative radiotherapy is one thing, when we do during the operation, if I'm doing an breast cancer, I'm removing a tumor, but always you have an microscopic disease around the tumor bed. So that what we do is we take out the tumor. During the operation theater itself, we just irradiate the tumor bed with an X-rays, which will sterilize the entire microscopic disease. So that is called intraoperative radiotherapy. During the operation itself, we give a radiation to reduce the microscopic spread, so that if you have an without any we can be without any cancer for a long time. And this is how the difference is. If you have, with the modern techniques, really we can give a radiation to one particular area where you want, and you can avoid all the critical structures. So in summary, radiotherapy is a well-established modality for the treatment of numerous malignancies. And radiation oncologists and specialists trained with the cancer variety form of radiation, and treatment delivery is relatively safe with all this imaging system and everything. We know exactly where we are treating with all this nuclear medicine imaging, radiological imaging. We know how focusedly we can target the treatment, and obviously we have seen a lot of patients get cured with radiation. And this is our hospital, it's on the back of a lake. It's a beautiful view of our hospital. And really, thanks for your attention. Thank you.
Thank you, sir. This question is from chat box by Ravi Shankar.
Yeah.
How to overcome the side effects after radiation therapy treatment? Discuss the valuable tips.
Okay. See, the thing is, as I showed you, with this modern technique, we can modulate the intensity of the radiation. Okay, so that we have a software, and we have an simulation procedures. We can simulate the patient on the treatment planning system, and we can model the radiation beams. How we are going to treat the patient, we used to model in the planning system. Because I have very less time, so that I cannot show you here. We have a software which can control the entire modulation of the intensity of the radiation beam, and we can give only radiation to the tumor cells and try to avoid all the other normal tissues. So that we have techniques, and we have an expertise, so that we give only radiation to the tumor cells, which is not going to create a lot of toxicity. So that with the newer techniques, obviously we can reduce a lot of toxicity by changing the intensity of the radiation.
Thank you, sir. Next question is by Kishanti. Which radiation is used for eye treatment?
See, eye is a different thing. It's the laser is not an radiation. Okay, obviously it's a beam. Okay, it's normally laser is the system we use for a cataract operation and other things. Normally they don't come as an ionizing radiation, but laser is the beam where we used as for cataract operation and other things. We use lasers, not the this X-rays. Laser is one which we use for an eye treatments.
Thank you, sir. Next question is by Sampath Kumar. Does isotopes affect the body when these isotopes get degraded in body?
Yeah, it's a very good question. Okay, thing is we give an isotope. Normally, these isotopes we talked about the half-lives. These isotopes give an emit and radiation. Also, the amount of an energy which emits the energy is also very less, and the isotope activity within normally if you see a technician, the half-life is something about 6 to 7 hours. Okay, so that within 7 hours, the activity will be very less. So that it will be very common, the patient can go out and be with the relatives. There is no issues. So the half-life of most of the isotopes are within 1 or 2 hours. So that normally before we discharge the patient, we used to measure the patient with the radiation survey meter. If the amount of radiation come out of the patient is it's allowable for in public, then only we discharge the patient. So that this see we always we use this radiation techniques for some benefit of the patient. Obviously there are some there are some publications about secondary cancers using this radiation, but it's the possibility is something about 0.1% because of this kind of radiation what we use for diagnostic purpose.
Okay, sir. Thank you, sir. Next question is by Lada Mercy. In what way PET scan differ from other scan?
Okay, PET is something about when you do a CT scan. Normally, what we see is we see the anatomy. We can see a liver, we see a kidney. Okay, but we cannot see the functionality of the kidney. Whether the kidney is functioning or not, we cannot understand. Whether the liver is functioning or not, we cannot understand. Okay, and so that we can really understand with this PET CTs, it can clearly give an functional imaging. Functional imaging meaning is like how a particular organ is functioning. Okay, so that using this perfusion and diffusion imaging, we can clearly understand whether the critical structures, all these organs are working properly or not. We can identify. The second thing, the advantage of the PET CT is you can identify for cancer staging purpose. Because see, I got a tumor in the breast, but it doesn't mean the tumor will be only in the breast. It can go into the brain. It can go into the bones. So that this PET CT scan will really help up. Before starting the treatment, I want to make sure that disease is not nowhere else, only in the breast. I need to find it has not spread to the other part of the body. So that this PET CT scan will really help us to identify this tumors are not spread. So that for the staging workup, it's really help. Only with the CT scan, it's really difficult to understand whether the disease has been spread to the multiple areas. So that this PET CT really help us to identify the tumor has spread to other areas. And the second thing is you can identify how the organs are working properly.
Thank you, sir. Next question is by Rajarajan. He's asking about cell therapy treatments.
Cell therapy treatment.
Yes.
Oh, okay. There is something called gene therapy. Is there? I never heard about cell therapy treatment. Okay. Because see, still they are in very early stage. It's not in the clinical application so far. Okay. Still, it's in the animal research what we can sell. Say it's something about changing the mutation of your cells and and just organ is not properly developed. You can inject and putting a gene inside and you're creating an organ. Still, it's not in clinically implemented so far. Okay, there are certain sites still people are trying it, but still clinically we don't have enough evidence that this cell or gene therapy is available so far. It's still in clinical stage, in research areas. It's not in clinical use.
He's also asked radio cobalt treatment of cancer, radio sodium improve blood cells in cataract treatments.
Especially radiation sodium, radio cobalt has been used for radiotherapy treatment. Okay, I don't think any isotope can be used for cataract. Cataract we can have to use only the laser. Laser is the only option. We don't use radiation for cataract treatments. Okay, and cobalt can be used for the cancer patients. There is nothing with sodium or other things. Cataract can be done only with the laser beams.
Just by Lada Mercy, ask people in scan center wear badges. What is this?
Okay, see, it's very important. As a radiation worker, we used to wear an thermoluminescent dosimetry badge. What it does is it records the doses because sometimes a lot of accident has happened. A patient, a radiographer who want to treat a patient was inside the room and we started the treatment. Okay, the radiographer also received the dose. So that our Indian Atomic Energy Agency (ARB) has an formulated a dose a radiation worker can receive at 20 millisievert per year. So that these badges will help us to understand how much dose we received for the entire year. If you receive more than 20 millisievert per year, normally we send these badges to the lab and they used to, because it records the doses. And it's a thermoluminescent dosimeter. You heard about TLEs, right? In the physics, using the trapping. Once you just give it heat, it gives a fluorescence, and we can measure the dose. So that it works on a thermoluminescent dosimetry method, and it records the doses how much I received. So that if it exits more than 20 millisievert, ideally I need to just away from the radiation work for some times. And if it exits more than lethal, then I have to do some chromosomal examination. How much dose I have received, I have to calculate. So that it's especially, this TLDs are help us to monitor how much radiation dose we receive, whether we are safe or not. That's the main reason we use this TLD badges.
Thank you, sir. Dr. Pungode is asked, how about dressing material for radiation? Is there any resistance materials?
Like lead aprons are available. Like, sometimes we used to do, like, for a diagnostic purpose. Like, a small kid was there. Like, we cannot, like, we can, with a small kit will not cooperate for an imaging purpose or a CT image purpose. So that we can ask the relatives or the patient father or mother. We can use a lead apron. Okay, so that this lead material is good enough to avoid the KV images. But during the high voltage, like, for radiotherapy purpose, we used to treat with an MV range. But this lead material cannot help. Okay, the lead materials can help only in the KV, only in the diagnostic purpose. We ask the patient to wear a lead apron and can stay inside, because this public, they are never exposed to this radiation. Receiving only one single dose of 1 millisievert or 2 millisievert is not going to, the possibilities of getting cancer is very less. So that sometimes we also, make the, parents of the small kid allow inside the, diagnostic X-ray room with a lead apron. The lead aprons are really good, to avoid the radiation for radiation workers as well as the public.
Okay, sir. Thank you, sir. How about radiation hazards in the scan rooms after giving a radiation to a patient?
Sorry, how about?
Sir,
Can you repeat the question?
yes, sir. How about radiation hazards in the scan rooms after giving a radiation to a patient?
Okay, it's a very good question. Okay, once like when we use an X-rays, once the machine is switched off, there is no radiation. That's it. Okay, radiation doesn't, it's not roam around in the air. Okay, so that once it is switched off, it is gone. But the problem is when you try to use an isotopes. Okay, and sometimes, we used to do some fluid isotopes, like, in the PET imaging we used to inject a fluorinating, okay, which has a half-life of something about 4 hours or something. When we got these isotopes with a higher half-life got spilled on the ground, okay, then there is a radiation hazard. Otherwise, this X-rays, this linear accelerators, once they are switched off, there is no radiation. But when there is a spillage, then we used to do the decontamination procedures to clean all these radioisotopes. We have a different procedure to clean all these things. But in X-ray room and other rooms, there is no radiation hazard. Once the machine is switched off, there is no radiation outside.
Sir, thank you, sir. There are many questions in chat box. We will mail it to you, sir. Thank you, sir.
Thank you.
Good evening, everybody. On behalf of the Department of Physics, we would like to extend a very hearty vote of thanks to the resource person and my dear friend, Dr. Karthik Raj Mani, for exposing and sharing his findings and opinions in application of radiation in medicine. You have given us an insight in radiation, which could be viewed as an technology in medical applications. We would like to take this opportunity to place on record my hearty thanks to Johnson Institute of Technology for the perfect logistic support and guidance they have extended to all of us at this webinar. We have been fortunate enough to be backed by a team of very motivated and dedicated colleagues, and I thank them for their enormous cooperation in the organization of this event. Dear participants, we thank you for being with us this evening. It's been a great pleasure. Thank you very much. Thank you, one and all. Have a great day.